It's my pleasure to welcome you to this important lecture on pulmonary arterial hypertension, which I'm pleased to say is sponsored by Actelion Pharmaceuticals, Bayer Healthcare, Gilead Sciences, and United Therapeutics, and you may understand why that might be. Lung issues in systemic sclerosis, I don't have to tell this audience, are tremendously important to understand, to continually test for and detect and hopefully get on necessary treatments as soon as possible. It is a continuing and major focus of the foundation because it is one of the most severe comorbid conditions of scleroderma, and we need to be all over this to ensure that our patients and the people that we love have the best outcomes as possible. So that's why I'm pleased this morning to welcome Dr. Robyn Domsic, our presenter. Dr. Domsic received her medical degree from the University of Iowa and completed her internship and residency at Duke University Medical Center. She went on to do her rheumatology fellowship at the University of Pittsburgh, working with the renowned scleroderma expert, Dr. Thomas Metzger, who I believe I saw in the back of the room there. She has subsequently finished her Master's of Public Health at the University of Pittsburgh as well, and she's board certified in internal medicine and rheumatology. Her primary clinical and research focus is improving the care of people with scleroderma. So please join me in welcoming Dr. Robyn Domsic.
Good morning, everyone, and I just want to thank the organizers for allowing me to give the talk today on pulmonary hypertension and systemic sclerosis. So I have no disclosures. When I sat down and thought about what I wanted to do in this talk, I tried to be the person who sits on the other side of the table and think about what I would want to know if I were a patient or if I were a loved one whose family member was being diagnosed with scleroderma. I wanted to know about pulmonary hypertension. And so I came up with a series of questions, which I've tried to answer in the talk today, and hopefully will answer a lot of your questions. However, I only have about 45 or 50 minutes worth of slides, so there'll be plenty of time at the end to ask questions if there's something that I haven't addressed and you'd like to know. So the questions I wanted to address today are: what is pulmonary hypertension? Reviewing not only the definition of pulmonary hypertension, but the different types of pulmonary hypertension, because pulmonary hypertension is a bit of an umbrella term, and review a little bit about the pathogenesis of pulmonary arterial hypertension and the other types. I wanted to ask the question of how is pulmonary hypertension diagnosed? Why is pulmonary hypertension important in systemic sclerosis? Which scleroderma patients specifically are at risk to develop pulmonary hypertension? And scleroderma is going to be abbreviated SSC throughout the slides you'll see. How do we screen for pulmonary hypertension? And then what are the available therapies for pulmonary hypertension? And we'll talk not only about the pharmacology or the medications available, but the non-pharmacologic therapies. We'll talk about how the therapies may differ based on the different types of pulmonary hypertension you have. Introduce the concept of pulmonary hypertension centers and multidisciplinary care for pulmonary hypertension. And then talk a little bit about the importance of clinical trials in scleroderma-related pulmonary hypertension. So first we'll start off with what is pulmonary hypertension. So as I mentioned earlier, it's an umbrella term, but its basic meaning is that you have high blood pressures in the blood vessels of the lung. It may lead to right heart dysfunction or failure, and it can be life-threatening, especially if it goes untreated. So I wanted to start off with just a diagram that shows you essentially the structure of the heart. So all mammals and birds have a 4-chamber heart. So it's made up of 2 smaller chambers at the top called the atria, which are up here, and then 2 larger chambers on the bottom called the ventricles. Now there's both left and right sides of your heart, and they have different functions. So the left side, which is here in red, pumps oxygenated blood, which is why it's colored red. It pumps it from the left ventricle up through the aorta, which is the main blood vessel in the body, and then it goes out through the circulation. And what happens is it takes oxygen to the tissues, which is exchanged and used by the cellular processes, and then the byproducts, including CO2, are sent back in deoxygenated blood, which will be colored blue. And it comes back through the vessels, the vena cava. There are 2 main ones. So the inferior vena cava brings blood back from the lower part of the body, and the superior vena cava brings blood back from the upper portion of the body. They dump into the right atria, which is right here. They go to the right ventricle, and from there they are pumped through to the pulmonary arteries. The pulmonary arteries then take the deoxygenated blood through the lungs, and they become into very small capillaries in the lungs. And they take them through the air sacs of the lungs, or what we call alveoli. And what happens here is that the deoxygenated blood comes by, and then through a process of diffusion, you get rid of the byproducts of cellular metabolism, so things like CO2, and then oxygen is diffused across from the air sac back into the pulmonary arteries. And as it becomes oxygenated and colored red again, this then comes back through the pulmonary veins, which are right here, dump into the left atria, the left ventricle, and then go on to the rest of your body, and the process begins again. So, looking at the blood pressures that you'll see in the pulmonary system as composed to the systemic system, so what do you think of as a normal blood pressure? Any ideas? I'm sorry?
In the lungs or
In the systemic circulation. Right, so 120/80, and that's what you'll see sort of in the arteries and when you take your blood pressure in your arm. And that 120/80 gives you a mean systemic pressure, which is around 70 to 90s. And this is what you'll have in the main part of the circulation. As you come down into the tissues and then return blood back to the heart, it becomes a little bit of a lower flow system. And then from the right side of the heart to the pulmonary artery, this is a very low system. And so we would typically see pressures of around 19/8, which is here, or what gives you a mean pulmonary artery pressure of around 8 to 20. Most commonly, people will see mean pressures around 11 to 17. Pulmonary hypertension, though, is when you have a mean pulmonary artery pressure of 25 or greater millimeters mercury, and that's the definition of pulmonary hypertension. So what are the symptoms of pulmonary hypertension? So the earliest symptoms are on the top top row here. So these include exertional dyspnea or shortness of breath. This also includes fatigue. As things progress, you can have additional symptoms. These include dizziness. It can be syncope or fainting episodes, which can happen with exertion. You can have edema or swelling of the lower extremities. And then you can have chest pain, which can be exertional. Unfortunately, though, these symptoms are fairly nonspecific. And so you can have shortness of breath and you can have tiredness for a lot of reasons. Tiredness certainly comes along with scleroderma. And so because they're nonspecific, people tend to just attribute them to other things. I'm deconditioned, I've gained weight. Even providers can sometimes misattribute them to other things. And so unfortunately, this can often lead to a delay in diagnosis, which is why it's important to be aware of it. And so some of the literature will suggest that up to 20% of patients with pulmonary hypertension may actually have symptoms for 2 years or greater at the time of diagnosis. So how is pulmonary hypertension diagnosed? So the gold standard, which is the main way of diagnosing pulmonary hypertension, is through a procedure called a right heart catheterization. So in a right heart catheterization, you put a catheter through a vein, which usually is done through the neck, but can be done through the arm. This catheter then goes into the right side of the heart and is fed up into the pulmonary artery. And there's a little balloon here which is inflated, and you have sensors which help you measure the pulmonary arteries. And then what you're looking for is a mean pulmonary artery pressure of 25 millimeters mercury or greater. There are other measurements that can be taken here that I'm sure you may have heard or looked at called pulmonary vascular resistance or wedge pressures, which can sometimes help you differentiate the type of pulmonary hypertension, which we'll talk about on the next slide. So this is the clinical classification of pulmonary hypertension, which has been revised several times. Most recently was done last year in Nice, France. And so there are 5 groups of pulmonary hypertension. We call them the World Health Organization or WHO groups. So the first one up here is group 1, which is pulmonary arterial hypertension, and that's what most people think of when we talk about pulmonary hypertension and systemic sclerosis. You can have pulmonary arterial hypertension, though, for a number of different reasons. So some people have it because it's familial or it's heritable. Others have developed it because it can be drug or toxin induced. So one of the things that we think about most in this case are the diet pills and fen-phen. Here is where you're going to see the connective tissue diseases. The most prominent of one is scleroderma. There's group 2, which is down here, which is pulmonary hypertension due to left heart disease. This can be because your left heart is not pumping well enough in systolic dysfunction, or it's stiff, which we refer to as diastolic dysfunction. It can be because of problems with valves, or it can be because of structural changes, congenital heart disease. Group 3, pulmonary hypertension, is due to problems in the lungs or hypoxia, where you have low oxygen levels. This can come from interstitial lung disease, ILD, also called pulmonary fibrosis. It can be associated with COPD or emphysema, which are smoking-related lung diseases. It can also happen if you have significant sleep apnea. Group 4 is chronic thromboembolic pulmonary hypertension, called CTEPH. This is a condition where you have repeated blood clots in the lungs, which eventually lead to high blood pressures. And then you have group 5, which is pulmonary hypertension associated with other multifactorial mechanisms. And this is where kind of other things are grouped. So it can come from problems with hematologic disorders or blood disorders, inborn errors in metabolism. So most importantly is that patients with scleroderma can actually develop pulmonary hypertension in three of these groups. So as I mentioned, the most common one is the pulmonary arterial hypertension, where the problem is in the blood vessels itself, and we'll show that in the next slide. However, you can also develop pulmonary hypertension from left heart disease. And in scleroderma patients, this is usually due to left heart failure because the heart becomes stiff. And this essentially happens because you actually have fibrosis, which can happen in the heart itself. You can also develop pulmonary hypertension associated with interstitial lung disease or pulmonary fibrosis. So you need to be thinking about all of these in patients with scleroderma. So just a couple of slides about the pathogenesis, or how pulmonary hypertension can develop. So my first slide is on pulmonary arterial hypertension, or group 1, which essentially is progressive scarring of the inner lining of the blood vessels. So if you look over here, over on the left is actually a normal blood vessel. So normal blood vessels have 3 layers. The innermost is the intima here, which has a very special layer of cells in it called the endothelial cells, which do a lot of the functions in terms of telling blood vessels to open up, vasodilate, or to close down, called vasoconstrict. You have the media, which is the thicker muscular layer here, and then you have the adventitia, which sits outside. So as pulmonary hypertension starts, you start with a normal artery. You can have risk factors, which would be scleroderma. And then you have an insult which happens. And most people think that this initial insult is injury which happens to that inner layer or the endothelial cells in the pulmonary artery. And this starts by causing an imbalance between vasodilator factors, or nitric oxide, and then vasoconstrictors, so chemicals that tell the blood vessels to clamp down. The most powerful one which we have in our body, which is called endothelin 1. So you start having problems with vasodilating and vasoconstricting, you get that imbalance. Endothelin 1 also by itself can trigger a little bit of fibrosis. In the early stages, you can also start to have problems with the muscular layer, the middle here, where the smooth muscles. And if you cut across these arteries or cross-section these arteries, what you'll see in the smooth muscle cells is that there are actually immune system cells or inflammatory cells in scleroderma patients. So immune system cells like B cells, T cells, and macrophages. And so in the early stages here, where you still have reversible diseases, you start to see a little bit of thickening of the intima here. You start to see that the smooth muscle cells in the media become a little bit thicker. As these changes progress, the blood vessel becomes progressively more scarred and more stiff, and it no longer really responds well to vasodilators and nitric oxide, and it becomes essentially irreversible. And what you'll see in this lesion are very thick intima, very thick media, the middle layer, but the adventitia also has become thick as well. You can actually start to have, because of the activation of the endothelial cells here, you can actually have blood clots and things that form in the process. And so our hope with pulmonary hypertension is to find someone who's more in this stage with reversible diseases that you control before it becomes this very thick vessel that doesn't respond very well. So this again is a slide on pulmonary arterial hypertension, but these essentially are cross sections where the arteries are cut across to show you what the artery looks like. So up here on the upper left is a normal pulmonary artery, which you can see just 3 layers, but a very nice regular lumen. Down here on the bottom left is the next one, and you can appreciate here that you're starting to get basically some early wall thickening at that point. As this progresses, you come up here to the upper right side, and you'll notice that you have some fibrosis beginning in the luminal wall. You can see that it's actually becoming quite thick, the lumen's becoming smaller. And then this is an advanced lesion. And if you look here, you can see that the wall of the blood vessel itself is very thick, and the lumen is very small, and that's what an advanced lesion looks like. So this slide talks about the pathogenesis of the other types of pulmonary hypertension. So group 2 is left heart disease, and this is referred to as pulmonary venous hypertension. And it's characterized by having high blood pressures in the left atria, on that upper chamber on the left side of the heart. And then essentially, when you have that high pressure there, this essentially causes a backup. So if you start with the left side of the heart and you're increasing the pressures here, that's backing up. And of course, your body wants to continue to push blood from the right side of the heart to the pulmonary arteries to oxygenate it, but you have this increased pressure coming from the left. And so the right side of the heart and the pressures in the lungs have to become higher in order to compensate for that and continue to move blood further. And that's sort of how you start to develop the pulmonary hypertension. How bad the pulmonary hypertension becomes in this type really depends a little bit on individual factors, which we don't entirely understand yet. Group 3, or the pulmonary hypertension associated with interstitial lung disease, has 4 mechanisms which happen. The first is hypoxia, or low oxygen levels. And when you have low oxygen levels, the natural body reaction is to clamp down or vasoconstrict those blood vessels. And this can contribute to wall changes in the arteries. The actual progressive lung tissue fibrosis itself can basically cause blood vessel destruction and kind of start to crowd things out. You start having fibrosis around the blood vessels themselves, which interfere with their ability to open and close. You can also, as part of this process, start to develop thrombosis or clots in the blood vessels. And these all can contribute to why pulmonary hypertension develops with interstitial lung disease. So let's talk about prevalence of pulmonary hypertension, or how common pulmonary hypertension is in scleroderma. So if you look at most literature, you'll read between 10 and 25% of patients with pulmonary hypertension can develop scleroderma, depending on who's been publishing and sort of how they developed their group to look at how common it was. So I actually took some data from the last 10 years, from 2000 to 2010, from our scleroderma data bank at the University of Pittsburgh. So during that time period, we saw 1,152 scleroderma patients. Of those patients, 113, or 10%, had group 1 pulmonary arterial hypertension. 23, or 2%, had group 2 left heart disease pulmonary hypertension. And 61, or 5% of our patients, had group 3 pulmonary hypertension associated from interstitial lung disease. And so we saw about a prevalence of around 17% in our clinic, which fits in nicely with the numbers that have been in the literature. It tells you it's obviously very high prevalence, because if you think about it, in the normal population, the prevalence of pulmonary hypertension in America is around 50 in a million, which corresponds to a percentage of 0.00005%. So quite a bit higher than in the general population. So why is pulmonary hypertension, either pulmonary arterial hypertension or the other types, important in scleroderma? So both PH and ILD are the most common causes of death in scleroderma patients. Survival with scleroderma-associated pulmonary hypertension is not as good as other types of pulmonary hypertension, and I'll show that to you in the next few slides. Pulmonary hypertension causes significant disability and morbidity, and it has a relatively high prevalence. So this is a classic paper that was published in 2003 from the University of Pennsylvania. And what it looked at this time was the survival of patients with scleroderma-associated pulmonary arterial hypertension compared to patients with pulmonary arterial hypertension for other reasons. Now, this paper was published in 2003, so these patients were kind of in the very early days of pulmonary hypertension. They used kind of standard therapies, and at that point, only IV epoprostenol or Flolam was available. But essentially what you can see here is that survival in scleroderma-associated pulmonary hypertension is much lower than in other types of pulmonary arterial hypertension, so that the mean survival, or 50%, was around 1 year. This was also shown in another paper that was done by Val McLaughlin and published a couple of years later, in which she looked at survival by the cause of pulmonary arterial hypertension, so group 1 pulmonary arterial hypertension. So you can see survival with congenital heart disease, if it was due to liver issues or idiopathic pulmonary arterial hypertension, and then collagen vascular disease or connective tissue disease here, and HIV showed a little bit lower survival compared to other types of pulmonary arterial hypertension. So similar to what we'd seen in the earlier studies, and that scleroderma patients don't do quite as well, which is one of the reasons, obviously, that we need to identify patients earlier. So then, Obviously, this is of a concern. So the question becomes is who with scleroderma is at risk for pulmonary arterial hypertension or group 1 pulmonary arterial hypertension? So there have been a number of things that have come up in the literature in various cohort studies. Something that's come up commonly in almost everything is that it seems like patients with limited skin thickening or limited skin disease are at a higher risk than patients with diffuse skin thickening. If you have an older age at your scleroderma onset, that seems to give you a higher risk for developing pulmonary arterial hypertension. We also know that there are specific scleroderma-associated autoantibodies, and we know that scleroderma-associated autoantibodies, people who have the same autoantibody tend to behave the same clinically. So certain scleroderma-associated antibodies may be associated with either limited or diffuse disease and with higher risk of developing internal organ involvement. So there are 3 scleroderma-associated autoantibodies which have been associated with an increased risk of pulmonary hypertension. The first would be anti-centromere, which is about 25% of the patients in the US with scleroderma. There's also 2 other antibodies which have a stronger association with the development of pulmonary arterial hypertension. One is called anti-THTO, the other is called anti-U3-RNP. These are a little bit harder to test for in laboratory work, so you can't always find them, but they do have a positive ANA and a nucleolar pattern. People have also associated that patients who have a lower progressive decline in their diffusion capacity, called DLCO pulmonary function tests, have an increased risk for pulmonary arterial hypertension. But as we'll talk about in the next few slides, as patients develop pulmonary hypertension, the diffusion capacity goes down. And so this is kind of a marker of the process that's going on. So who with scleroderma then is at risk for developing groups 2 and 3 pulmonary hypertension? So obviously, if you have a patient with interstitial lung disease or left heart diastolic dysfunction, you'll be at increased risk to develop these types of pulmonary hypertension. Males have been shown across the board to be at increased risk for group 2 and group 3 pulmonary hypertension. Again, there's been that association with an increased risk if you have limited skin disease. And there's been one autoantibody called a U11-U12 antibody, which has been associated with an increased risk for group 3 pulmonary hypertension. And this is probably because this particular autoantibody is associated with a very high rate of 70 to 80% of patients having interstitial lung disease. So one question that comes up, I think, is when does pulmonary hypertension occur in scleroderma, and when should we be looking for it? So this is a slide that I have borrowed from Dr. Metzger that goes over the usual timing of internal organ involvement for scleroderma patients based on the amount of skin thickening they have. So whether or not they have diffuse skin thickening, which is colored in blue here, or whether or not they have limited skin thickening, which is colored in red over here. So patients with diffuse disease, when they have their disease onset, they very quickly develop skin disease, usually hitting their peak skin disease or extent of skin thickening at around 12 to 18 months. And the majority of internal organ involvement actually happens or starts to occur during this time period where the skin is becoming worse. And so if you look in our database, by 2 years of disease, patients with diffuse scleroderma will have developed 90 to 95% of their internal organ involvement. This is different than for patients with limited scleroderma. These patients tend to develop internal organ involvement over many, many years. And so patients can actually develop new internal organ complications even 20, 30 years or decades into their disease. The exception for this rule, though, in terms of what new internal organ involvement can occur is actually pulmonary hypertension. And that is that pulmonary hypertension is one of the few late complications that can happen in diffuse scleroderma patients. And so you can have pulmonary hypertension really later in both diffuse as well as limited scleroderma patients. So the importance of screening is something I wanted to talk about. So the frequency or the prevalence of pulmonary hypertension, combined with the fact that there are these non-specific, hard-to-diagnose symptoms of pulmonary hypertension, and the fact that there's really very poor survival in untreated disease, provides a strong rationale for why we should screen for pulmonary hypertension in scleroderma patients. So when we think about screening, whether it's for pulmonary hypertension or screening for cardiovascular disease or other risk factors, there are some general principles of screening. So a screening test should lead to diagnosis at an earlier stage. It's also beneficial if the screening process itself will lead to improved survival or reduced disability, which is obviously linked to diagnosing at an earlier stage. Screening, though, should be cost effective, and it should be less invasive than the gold standard for diagnosis, which in the case of pulmonary hypertension is right heart catheterization. So before I kind of go over the next couple of slides, which talk about when to diagnose and how early to try and diagnose patients with pulmonary hypertension, I wanted to introduce this concept of the World Health Organization, or WHO, classification of functional status in pulmonary hypertension patients. And this functional status classification is a way that we assess essentially severity of pulmonary hypertension by looking at how well patients can function. It's also something that we follow in terms of whether or not therapies may be working. So one thing we would hope that if somebody's on an effective therapy, maybe their functional class would get better than it had been previously. It's also an outcome that we look at when new drugs are coming to market and are being tested in clinical trials. So the WHO classification, class 1 is essentially a person who's asymptomatic. So there's no limitation of usual physical activity. Ordinary physical activity doesn't cause any fatigue, shortness of breath, or other symptoms of pulmonary hypertension. Class 2 has mild limitation of physical activity. So a patient with class 2 functional status will be comfortable at rest, but normal physical activity might cause a little bit of increased fatigue, some shortness of breath, maybe some chest pain or presyncope, which is the feeling that you're about to faint. Class 3 patients have a little bit more marked limitation of physical activity. These patients are still comfortable at rest, but less than ordinary activity can cause fatigue, shortness of breath, chest pain, or presyncope. So this would be someone who maybe starts having symptoms when they're trying to do their laundry at home. Class 4 symptoms, which is the worst functional status, patients really are unable to do any physical activity. They're uncomfortable at rest, they have symptoms at rest, or they have signs of right heart failure. So while they have the symptoms at rest, essentially any physical activity at all, even doing activities of daily living, will increase their symptoms. So when thinking about the effects of screening, we want to ask, does functional status or does severity of pulmonary hypertension affect your survival? And so this data comes from the PHARO study, which is a multi-center observational study of patients who, with a recent diagnosis of pulmonary hypertension or with abnormal echocardiograms suggesting that they could possibly have pulmonary hypertension. And it's observational, so they've been followed over several years. This is multi-center and is done in the US, run by Jenny Steen out of Georgetown. And when you look at survival on these patients who have been followed for a number of years, their baseline functional status at the time that they were diagnosed and initiated on treatment actually was associated with better survival. So a higher functional class had better survival. If you had the lowest functional class, class 4, obviously that placed you at a lower level of survival. So clearly, if we can diagnose patients in an earlier stage of disease, that would improve survival. So this sort of shows kind of a rationale for why screening and getting an earlier diagnosis would be helpful. There's only been one study that's looked at whether or not giving a systematic screening program for pulmonary hypertension can actually improve survival. And this is a small study that was done in France of a total of 32 patients. So they looked at 16 patients who had been diagnosed with pulmonary hypertension based on routine care. So they had gotten their diagnosis just based on their symptoms and their provider deciding when they needed a right heart catheterization. And they compared it to 16 patients who have been diagnosed with pulmonary arterial hypertension, but had been part of a one-year study where they had been doing systematic screening of pulmonary hypertension. And this screening basically consisted of yearly echocardiograms, and then patients would go on and get a right heart catheterization if they had a certain number called a tricuspid valve regurgitation on their echocardiogram, or if they had a lower number in symptoms. And what they showed here is that in those patients who had their diagnosis of pulmonary hypertension, found through the systematic screening program that their survival was better than those patients who have been diagnosed by routine care just based on symptoms and their clinician. And this significant difference in survival was found very early at 1 year, but continued through several years out. So this certainly supports the idea that screening can improve survival in scleroderma-associated pulmonary hypertension. So now that we've talked about how it can be beneficial, the question becomes, how do we screen for pulmonary hypertension? So there are a few tests that are part of the screening for pulmonary hypertension. The first and most common one is the transthoracic echocardiogram. And this is universally available. It's non-invasive testing. It uses sound waves to basically image chambers of the heart. It's relatively inexpensive, and it estimates pulmonary artery pressure by measuring something called the tricuspid regurgitation velocity. So echocardiograms are nice and they're easy for patients, but the problem is the echocardiograph itself is not perfect. It can be particularly inaccurate if pulmonary hypertension is mild or if it's associated with interstitial lung disease, so if it's a group 3 pulmonary hypertension screening. And there can actually be a 40 or 50% discrepancy between the estimated pressure of the pulmonary arteries by echocardiogram, and that's directly measured at right heart catheterization. So echocardiograms themselves are not a perfect screening tool, unfortunately. There are other methods of screening, other tests that we use. So one is the pulmonary function test, or PFTs, and the diffusion capacity, or the DLCO, can be helpful. And in this portion of the pulmonary function test, you're essentially measuring how well gases diffuse from the air sac across the pulmonary arteries themselves and come back. And we know that if you have a low DLCO, particularly one that's less than 50%, that this can help identify patients who have pulmonary hypertension, and that can be high specific, meaning that when it's that low, there's a good chance. The problem, though, is that just using PFTs alone and looking at the DLCO actually misses a fair amount of pulmonary hypertension patients, so it's not very sensitive. And a test is sensitive when it picks up the majority of patients who have the disease. There's also exercise echocardiograms, which are done and can look at pulmonary hypertension or pulmonary artery pressures at rest and with exercise. In terms, though, of guidelines for screening, there have been a lot of papers that have been published by individual authors, as well as some more recent consensus guidelines. There are some things in which all agree should happen, and that is in terms of screening that there should be pulmonary hypertension screening at baseline and during follow-up of a patient with systemic sclerosis. Many of these recommendations recommend yearly echocardiograms. Others, however, suggest echocardiograms every other year. Some suggest that you do yearly echocardiograms on high-risk patients, with less frequent echocardiograms done on those without symptoms or who have normal diffusion capacities by PFTs. Others recommend that you go on to right heart catheterization if your echo shows a PA pressure of greater or equal to 40. In terms of position papers on it, some suggest that PFTs be done annually initially and then maybe less frequent in later disease stages. Now, the ACCP, which stands for the American College of Chest Physicians, has a formal clinical practice guidelines for the detection of pulmonary arterial hypertension, and these guidelines apply to everyone. However, there are a couple of specific ones that are for patients with systemic sclerosis. So they do suggest that echocardiograms be used for screening for all patients at high risk or with symptoms suggestive of pulmonary hypertension, so shortness of breath with exertion and fatigue. And in patients with systemic sclerosis, they suggest that PFTs with diffusion capacity should be done periodically, every year or so, to improve detection of either pulmonary vascular problems, so PH, or interstitial lung disease. Now, last year, and this was published in December of 2013, there was a consensus recommendation written for the screening and detection of pulmonary hypertension in scleroderma patients. This was actually supported by the Scleroderma Foundation and the Pulmonary Hypertension Association. And so in order to get these recommendations, they use expert consensus methodology called the RAND and UCLA methodology. And this is a well-recognized and respected way of coming up with these consensus guidelines. So the steps that were used, the first one included a systematic review of the literature for pulmonary hypertension in scleroderma by a core panel. And this core panel consisted of one rheumatologist and one cardiologist. And their job was to do a quality assessment of the literature on pulmonary hypertension in scleroderma, and then to prepare a scientific evidence report and some case scenarios which raise questions about diagnosis of pulmonary hypertension and screening in scleroderma patients. Then they did this, and they gave this to a diverse group of experts called a task force, which consisted of 3 rheumatologists, an internist, 4 pulmonologists, and 2 cardiologists, all who had published or had experience with pulmonary hypertension. And in the first round, the task force basically kind of ranked screening possibilities and a risk versus benefit ratio. And in their second round, they did a face-to-face meeting to talk about what the consensus guidelines should be. So the key recommendation that came out of this consensus was that all scleroderma patients or patients with mixed connective tissue disease who have scleroderma spectrum features should be screened for pulmonary hypertension. So the initial screening evaluation should include pulmonary function test with diffusion, echocardiogram, a measurement of NT-proBNP, and BNP is essentially a measure of the stretching of the heart, which is done in serum testing, and then the detect algorithm if appropriate, which we'll talk about on the next slide. They recommended yearly echocardiograms and PFTs with diffusion capacity for screening, with only doing the serum NT-proBNP test if there were new signs or symptoms which had developed in patients. And they felt that right heart catheterization should be mandatory for diagnosis. So essentially requiring right heart cath and no longer just using echo numbers in order to diagnose pulmonary arterial hypertension or pulmonary hypertension. So the DETECT study was an early, simple, and reliable detection of pulmonary arterial hypertension and systemic sclerosis, was the name of it. And the goal of the DETECT study was to establish a simple and reliable screening tool for the early detection of pulmonary arterial hypertension and scleroderma. So this was a prospective, meaning it started and looked forward, observational cohort study. It was international, done at 62 centers, and it looked specifically at patients who were high risk for scleroderma-associated pulmonary hypertension. So these were patients who'd had disease for at least 3 years, or who had an echocardiogram which already showed that there was reduced diffusion capacity. So always something that could indicate that there might be a problem with the pulmonary vessels themselves. And what they did in this study was they tried to evaluate more than 10 screening tests and their combination to see if there could come up with a better algorithm to detect pulmonary arterial hypertension in scleroderma patients. So the screening tests consisted of blood tests, history tests, kind of characteristics of the disease, but also echocardiograms and EKGs. And so what they came up with was an algorithm that identified almost 2/3 of patients who needed a right heart cath accurately. And it's 2 steps, and this is kind of a busy, small slide. So I'll try and make it concise for you. So the first step here, they use this nomogram to look at a number of factors, which includes some PFT reports, whether or not you have telangiectasias, if you're centromere positive, EKG, and some serum markers with the BNP and uric acid. And if you hit a number of greater than 300 or more, then this suggested that you needed to have an echocardiogram done for screening. And if you take these numbers, you can go into step 2. So you use this number, and then you add to it some measures from the echocardiogram, and then this will tell you if you have a number greater than 35 that you need to go for right heart catheterization. So the DETECT study kind of produced a nice sensitive tool in that it reduced the amount of missed pulmonary hypertension to around 4% when you use this algorithm to decide who needed a right heart catheterization, which is opposed to an estimated 29%, which is missed according to the other literature in scleroderma-associated PH. And when they developed this, they really used a nice methodologically sound approach because they required all patients to have a catheterization to determine whether or not they had it. The thing, though, I think there are some things to think about when you consider this for clinical practice. This algorithm is designed for use in specific high-risk patients who have abnormal PFTs, so you can't really apply it to everyone. And it still does require a number of tests to be performed, some of which are not really routinely part of the scleroderma patient care. And in order to really use this model well, you have to have essentially everything. You can only have one variable or one test that's not missing. Otherwise, the model does not accurately predict things. So at this point, I'm going to go on to therapy. So the first question I wanted to ask and try to answer is, how do we assess how a patient is doing on therapy or in a clinical trial? So there are a couple of different things we do. So there are obviously a number of objective measures, which are the top 3 here. So this includes 6-minute walk distance, abbreviated 6MWD, and that's how far a patient can walk in a period of 6 minutes. It's also the WHO functional class that we talked about in earlier slides. And then there are also measures that we call hemodynamics on right heart catheterization. So what's happening to your mean pulmonary artery pressure with therapy, what's happening to the reg pressure, the pulmonary vascular resistance. And then not to be forgotten is actually how the patient is feeling. How are they able to do things? What is their quality of life when we're talking about whether or not a therapy is effective? So the drug therapy and the approach to pulmonary arterial hypertension, that group 1, is different from either pulmonary hypertension related to interstitial lung disease or left heart dysfunction. However, the non-pharmacologic therapy is similar. So this slide shows the medications which are available for the treatment of pulmonary arterial hypertension. And this is a busy slide, which is a good thing, because 10 to 15 years ago, as you know, this slide was much shorter. So this now has 13 medications on it, and you'll see that 3 of them are bolded in kind of black, kind of a broader bold font. And those are the 3 drugs which were approved by the FDA for the treatment of pulmonary arterial hypertension last year. So these include oral treprostinil, or Remodulin, which was approved in December, macitentan, which is an oral agent and that is used, and then most recently risavuat. So there are 4 different classifications, 4 different classes of drugs now that we use to treat pulmonary arterial hypertension. The first is prostacyclins, which essentially are vasodilators, which open up blood vessels. And we have epoprostenol or Flolan, treprostinil, available in different mechanisms of administration, and iloprost. All of these have some common side effects, which include headache, jaw pain, and flushing. You also have these endothelial receptor antagonists, all of which are oral medications, which are used. Some of them can have side effects and require liver monitoring. The other 2 tend to have some anemia and require some monitoring of blood counts. PDE5 or phosphodiesterase 5 inhibitors essentially are also vasodilators, which open up blood vessels. There are 2 approved. One is sildenafil, which is also Viagra, and then tadalafil. These tend to be fairly well tolerated, but they have in common with them all headaches, a little bit of GI symptoms. And then risavuat, which is what we call a guanylate cyclostimulant, which works in a different mechanism. It increases cGMP, which increases vasodilation, is new, approved last November, I believe, and its main side effect is it decreases the blood pressure. So when we look at modern-day survival in scleroderma pulmonary arterial hypertension, if you remember the first couple of slides I showed you, which showed that there is a big difference between patients with scleroderma-associated pulmonary hypertension and non-scleroderma-related pulmonary hypertension. If you remember, the mortality rate was around 50% at a little over a year. When we look at modern-day survival, so using our currently available therapies, things do look better for patients with scleroderma-associated pulmonary arterial hypertension. So this again uses data from the PHAROS study, that multi-center observational study here in the US. And when it showed that 1-year survival with pulmonary arterial hypertension was 93%, and 3 years was 75%, so much better than it had been 10 years ago. This is similar to modern-day survival in a French cohort that was published a couple of years ago using a total of 86 patients. And what they reported was a 1-year survival around 90%, so similar to what we had in the US, and a 3-year survival around 56%. So still significant gains compared to 10 years ago. So therapy for pulmonary hypertension related to left heart disease or group 2. So the primary treatment for this actually is management of the underlying heart disease. So in scleroderma patients who have a diastolic dysfunction or stiffening of the heart, this can include medications to control the blood pressure. It can include medications to reduce fluid retention or diuretics, and also to slow down the heart or reduce the heart rate, which can be beta blockers or calcium channel blockers. And in some patients, they'll use medications that increase the force of the heart contractions called inotropes. The pulmonary arterial hypertension medications that I showed you on the prior slide, though, are generally not used in this group of patients because the underlying pathogenesis is different. As far as therapy for pulmonary hypertension related to interstitial lung disease, one of the mainstays and very important things is oxygen therapy, because hypoxia and low oxygen levels can really kind of drive the pulmonary hypertension. And so oxygen therapy in this group of pulmonary hypertension is really shown to have survival benefit. The benefit, though, of the pulmonary arterial hypertension medications in this pulmonary hypertension associated with ILD is a little bit unclear. There was a retrospective study of 70 patients, which were combined patients from Johns Hopkins here and then from a center in France, saw no change in the objective measures, so the 6-minute walk distance and the functional class or the right heart cath numbers after about 7 months of therapy for PH medications in these patients with PH-associated ILD, they actually found that what predicted a worse outcome in these patients was whether you had worsening oxygenation or worsening kidney or renal function. But the reality is that many of us have used or had patients who have been treated with pulmonary arterial hypertension medications who have had this type of pulmonary hypertension, and some patients certainly do feel better and function better. So it can be a little bit different approach depending on where you are. One thing, though, is that it's appropriate to consider lung transplant evaluation early in a patient who has scleroderma-associated interstitial lung disease and pulmonary hypertension as a complication. So there are some therapies, which I mentioned, which can be common to all types of pulmonary hypertension. So oxygen therapy, I specifically talked about with ILD, but it can also help any pulmonary hypertension patient who is hypoxemic or has low oxygen levels at room air. Diuretics can be used to treat the fluid retention, regardless of the type. Exercise is very important, maintaining exercisability. This, though, of course, should be under the guidance of your physician. And then anticoagulation or blood thinners are something that's used in some types of pulmonary hypertension. It is a little bit controversial in the benefit for scleroderma patients. Lung transplantation is also an option, which may be appropriate for some patients with both scleroderma-associated pulmonary arterial hypertension, scleroderma PH related to interstitial lung disease, or scleroderma-associated ILD. It's true that not all lung transplanters will consider patients for lung transplant if they have esophageal problems because there's a concern of greater complications. A recent meta-analysis, though, suggested that scleroderma patients fare as well with lung transplants at 1 year as are patients who are getting lung transplants for reasons other than scleroderma-associated problems. And so I have the fortune of practicing at the University of Pittsburgh Medical Center, which is a big transplant center. And so far to date, they have transplanted 98 scleroderma patients. And actually their survival is actually quite good. And so if you look at patients who are transplanted for scleroderma, which is the black line, and those which are transplanted for pulmonary fibrosis not associated with scleroderma, there actually is not a difference in survival using the UPMC patients. Now I wanted to talk a little bit about pulmonary hypertension centers, their concept, and how they can be very helpful in managing patients with scleroderma-associated PH. So recent studies suggest that the algorithms are not always followed to completion in pulmonary arterial hypertension patients, and so that the long-term outcomes may not be optimal. And so the Pulmonary Hypertension Association, or the PHO, plans for a phase-in accreditation of what they call PH care centers. And these PH care centers are basically developed with kind of the following concept, and that is that you're going to have a patient with pulmonary hypertension who sits in the middle, and that there are going to be all these multidisciplinary options available to help manage a patient with pulmonary hypertension. So these would include, obviously, a pulmonary hypertension physician who can be a cardiologist or pulmonologist. And a patient of scleroderma would obviously involve the active participation of a rheumatologist, a social worker to help with the issues in terms of obtaining medications, physical therapy, rehab if needed, a nutritionist to help with dietary concerns such as salt intake, maintaining a healthy weight, a rehabilitation program available, and then having pharmacists available. And so the PHA is suggesting 2 different levels. So they'll have a regional clinical program which requires at least 25 pulmonary hypertension patients. And then you'll have these larger centers of comprehensive care, which will manage at least 75 patients with pulmonary hypertension and require these centers to be involved in research to have ongoing clinical trials. And so sort of the bottom line, though, is that people recognize the importance of multidisciplinary care in managing a patient with pulmonary hypertension, particularly in a scleroderma patient who has other issues as well. So I think one question is, if I have pulmonary hypertension, what can a patient do to help yourself? So there are a couple of things to think about. One is to watch your sodium intake, and usually a physician, your pulmonary hypertension physician, will give you guidelines as to how much sodium you can take, and this can change over time. To watch your fluid intake as detailed by your physician, to obviously maintain a healthy weight, to exercise as much as possible, although this should be with input from your PH physician, to avoid tobacco products, which of course should not have to be stated at all in scleroderma patients with the Raynaud's issues. Women of childbearing age should discuss contraception and the risks of pregnancy with their provider. Be aware of high altitudes, dehydration, and excessive humidity, which can worsen the symptoms. Be aware of over-the-counter decongestants, and obviously don't use diet pills, which seems counterintuitive to the idea of maintaining a healthy weight. The diet pills can have some pulmonary things. So just a couple slides on clinical trials. So the goal of a clinical trial is to develop safe and effective therapies and bring them forward to patients. So in orphan diseases such as both scleroderma and pulmonary arterial hypertension, participation in early and late clinical trials is important, as without patient participation, new therapies cannot be assessed and approved by the FDA. And I used a quote from the PHA Association that says, "Without this field can only advance on the scientific level, but patients won't ever get to use new therapies." So bringing a drug to market for PH can take quite a long time, so anywhere from 4 to 10 plus years. It starts with a preclinical phase where drugs are tested in animals. It goes on to phase 1 trials where you look at drug safety and find the dose that's appropriate in healthy people. Phase 2 trials start to look at the drugs in sick populations, so like a scleroderma population or pulmonary hypertension population. It begins to accumulate evidence on if a drug helps patients or efficacy. And then phase 3 trials establish whether the drug helps patients or not and compares it to placebo or standard of care therapies. Phase 3 trials are larger and longer than phase 2 trials. So I wanted to spend some time on what I think is a very important trial for scleroderma-associated pulmonary arterial hypertension. And this is a trial that's currently ongoing on rituximab. So this is an NIH-sponsored trial. It's a phase 3 trial for patients with scleroderma-associated pulmonary arterial hypertension on stable drug therapy. Now, rituximab is a drug that targets B cells, a cell component of the immune system. Rituximab is a drug actually that's been on the market for nearly 20 years. It was used initially for the treatment of Hodgkin's lymphoma, but has also been FDA approved for the treatment of rheumatoid arthritis for the last several years. So scleroderma, as you know, is an autoimmune disease, and it turns out that B cells, which is the target of rituximab, are found in the arteries of scleroderma pulmonary arterial hypertension patients. So these are cross-sections of pulmonary arteries. And what you see here, staining kind of the red, are actually the B cells. And so this gives us a rationale for using rituximab in PAH associated with scleroderma. So the inclusion criteria for the study are that you be 18 to 75 years old, you have scleroderma, and you have scleroderma-associated pulmonary arterial hypertension for less than 5 years, and that you stay on stable drug therapy, and you can't have had any changes in your meds for the last 4 weeks. It's important to point out, though, that this is an add-on therapy, so patients would remain already on their pulmonary arterial hypertension therapy throughout the trial. And so patients are randomized 1-to-1 to getting rituximab on top of their standard therapy versus placebo on top of their standard therapy. And this is a trial that lasts 6 months, but participants are actually followed for almost a year. And rituximab is actually just infused twice, once at day 0 and then once 2 weeks later, and that's it. So there are a number of sites which are recruiting for this currently, and they are listed here. So you can see that they are all over the nation. And if you have scleroderma-associated pulmonary arterial hypertension, I think this is a very important thing to consider involvement in, because it really is the only trial that's out there specifically for scleroderma-associated PAH. So I wanted to finish up with some take-home points and then any questions you have. So pulmonary hypertension can be a complication of around 1 in 5 scleroderma patients. Early diagnosis and treatment because of the pathogenesis is crucial. Screening is very important, and I believe it can be customized to patients and their risk factors. There are pulmonary hypertension therapies and management strategies are available, and this is an active area of research. But education of patients and healthcare providers is fundamental for both PH screening and management. And clinical trials are fundamental in moving treatment of PH and scleroderma forward. And so that's all I have. So I don't know if you have any questions. There are microphones on the sides. So, do you want to come up? Or maybe we can bring it to you. Thank you.
Doctor, I've had a right heart cath and it was okay. How often do you have to have that right heart catheterizations for testing? I mean, I don't have the pulmonary hypertension, I have pulmonary fibrosis at this time, and wondering if it develops, but I did have the right heart cath and it was negative. So I was wondering how often you would do that.
So in terms of screening, you usually need the right heart catheterization once, obviously, if you have it. If not, then usually they will not repeat it again unless a couple of things happen. So either you start feeling worse and they don't have an explanation, which is harder, of course, in patients with pulmonary fibrosis than other patients, or if something else changes on your screening parameters. So if you would have like an increase in your echocardiogram or your DLCO and your PFTs would come down. As far as how often right heart catheterizations are done in management of pulmonary hypertension patient, that can vary, and it varies between patients. So patients who are doing really well and stable really don't need them all that frequently and may only have one or two throughout it. And patients who are progressively having problems may need a little bit more, but it can vary between individuals, for sure.
Thank you. I was just curious. Thank you.
No problem.
My question goes beyond the scope of your presentation, but it is lung-based. So I'm interested in any comments you can make regarding lung cancer, relational issues between cancer and the other situations that we're aware of for scleroderma patients, prevalence, or any comment that you can make regarding that and how it fits in with the other conditions for scleroderma patients and lung issues.
So I think that's a complicated question. I think honestly it's one that we don't really have all the answers to. There really hasn't been a link in terms of scleroderma-associated pulmonary hypertension and lung cancer. There have been some studies which suggest an increased risk of lung cancer in scleroderma patients. These have predominantly come out of the Netherlands. There has been some discussion of whether or not there may be more increased lung cancer because of the underlying fibrosis and changes which are occurring. More recently, that hasn't always been found to be quite as true, and there have been some other associations between certain antibodies, such as RNA polymerase III, and cancers in scleroderma patients, and can they occur together? But I think the honest answer is that we don't have a complete concept of it. I think you also have to take it in the context that if you look at autoimmune diseases across the board, these are problems with the immune system. And the immune system is clearly very important in monitoring and detecting for cancer. And if you look at autoimmune diseases in general, you're going to find increased cancer rates across the board. So whether it's in lupus or rheumatoid arthritis or Sjogren's syndrome.
I have been a runner all my life, and now I can walk on my treadmill pretty good, and I'm satisfied with that cardio. I can walk along, I can increase it a little bit, and I'm fine, I'm not short of breath, but the minute I walk upstairs, I have to stop and gasp for air. So I have had echocardiograms and they keep coming back okay. So is that something I should be concerned about? My doctor says that my echoes are fine. In fact, he said I don't need any more echoes. But for me, that's something new, is walking upstairs and having to stop and gasp for air, but yet, and I do get fatigued when I do my treadmill, but he says I'm fine. So what do I do at this point? Do you think that's okay? That's normal? Because I'm getting older, I'm just a little confused about all that.
All of that. And you're exercising regularly, it sounds.
I exercise. I can't do it on an incline. I get too tired. But I've been a runner all my life, so when I explain that to him, he just doesn't really respond. He just says, your echoes are fine.
So I think one thing that you could ask about is whether or not your pulmonary function tests are looking okay, whether or not your diffusion capacity is looking okay. And then if you want to talk later, I'm certainly happy to talk with you later.
Is the risk for pulmonary hypertension greater with multiple risk factors? Like in my case, I have asthma. They also found a low diffusion capacity, and I also have sleep apnea. So does that make the risk for pulmonary hypertension higher, combining those?
Yes.
Okay.
Yeah, how much that does, though, and how much they interact, we don't really know. But I said how much they act like synergistically or how much they compound each other. we don't really know. But obviously, if you have multiple risk factors, you're someone who needs to be watched probably more closely than somebody who didn't have those, along with
Okay.
like the sleep apnea and things.
And then the other one is, you mentioned being hypoxic. So is that defined as your oxygen saturation being low in rest, at rest?
Yes. Or when you exercise, there's an exercise desaturation test. So if you're actually walking and you desat, into the 80s and things, and that's considered hypoxia
So,
too.
when you say low, is that anything under 90, anything under 95?
Usually under 90. I think the U.S. government requires oxygen therapy at 88%
Okay.
or less with exertion.